quite a packed afternoon, so we need to keep moving. So my colleague and friend, Dr. Saeeda Paruk, is a child psychiatrist, one of the very few child psychiatrists in this country with a PhD. She's done excellent work in terms of trying to build up research capacity in my department, and so we're looking forward to her talk on first episode psychosis. Over to you, Saeeda. Thank you.
Had a good lunch. My fear is that you don't fall asleep on me. Postprandial period. So please try and stay with me. Today we're going to be I was asked to speak about research and what's happening at UKZN, and I thought we would use the example of a small study that we are currently doing at UKZN for a few years to illustrate how we have learned about both the research process and about our clinical population, and use this study to help build research capacity, and therefore give you an example of the type of work people could do in settings where there hasn't been research previously, and you want to start building some sort of project that helps emerging researchers, especially clinician researchers, get involved in mental health care. So I'm going to talk to you a little bit about the background to this research project and the setting it is in, discuss the aims and objectives of the project so you can see what we are doing, a little bit of a study update and the kinds of research outputs we've had to date, and my reflections on this journey. So in terms of disclosures, I want to thank our study funders. We've had good fortune of receiving funding from the NRF and the South African Research Council, and also the Biological Research Established Researchers Award, which is part of the next Congress that some of you are attending. So, having all of you traveled now to South Africa, you know we are in the southern tip of Africa, but our study is set in KwaZulu-Natal, which is on the eastern coast. It's a lovely province. Hope you're all going to visit. We have lovely coastlines. I'm going to say better than Cape Town's. And we also have Drakensberg. I don't think it competes with Table Mountain, but still quite scenic and pretty. And we are fortunate to be coming from the University of KwaZulu-Natal and belong to the Nelson R. Mandela School of Medicine. Dr. Lisa is our head of psychiatry there. The reason I put up the slide is also to maybe give you a little bit of background. So the Department of Psychiatry at UKZN is a great department. As a university, we're one of the leading universities in terms of research. But unfortunately, our department 10, 15 years ago didn't have much research capacity. It's one of the reasons we lost Prof. Lisa for a while. He came along to Western Cape to do his PhD. And so we were often a department that had very minimal research output, maybe a few articles, conference presentations, but not too much and not much mentorship. So coming from that type of background, we wanted to obviously look at how we could build our department in terms of research capacity. So both Prof. Lisa and I had completed our protocols in psychosis, especially first episode psychosis. His was on adults and mine was on adolescents. We were fresh after our PhDs, and we worked together to develop this protocol called Burden of HIV and Psychosis in an African Setting, a longitudinal study of HIV-infected and non-infected patients with psychosis. So we really started working on this around 2018 and probably began data collection in 2019. So we are fortunate to be supported by a really great team of clinician researchers. We have T. Naidu, who's a clinical psychologist overseeing all the cognitive work being done in the study. And then really great PhD students who have really driven the recruitment and collection of data. And we also have a biostatistical support from our collaborator in the Department of Public Health, and also are fortunate to be able to store blood samples, etc., in the clinical medicine lab. So we don't have lots of funding, we don't have research project coordinators and writers, etc., but we do try and use whatever we have. Also the context of the study setting. So KwaZulu-Natal is a province that has a lot of poverty, high rates of unemployment, poorer access to mental health care than I would say maybe the Western Cape and Gauteng. Our services are very limited to urban areas with very little access to specialists in a rural area. Child psychiatry barely exists. So it is a very challenging clinical setting. There's a lot of inequality and economic disparity from the past. We have high rates of HIV, one of the epicenters in the world. Substance use continues to rise, and we have the introduction of more and more toxic substances over time. And more recently, the province has been particularly hit by the COVID-19 pandemic and its associated lockdown experiences, which has had significant psychosocial impact on the population. We then had a lot of flooding in our province particularly, and then we also had some unrest and looting, etc., which has all impacted on people psychologically and psychosocially. So against this backdrop, we look at the problem. We had HIV, and we currently are aware that HIV still remains a problem in sub-Saharan Africa. About 8 million people are living with HIV in South Africa, making it the country, the epicenter of the HIV pandemic. And KZN, and especially the eThekwini region where we work, remains one of the hotspots in the country. Living with HIV has been linked with a higher risk of mental illness, and we know that there is a bidirectional association between psychosis and HIV, with the comorbidity lending to a poorer outcome. So there's been many papers on this. The other area that interested us was obviously first episode psychosis, which possibly is now better termed new onset psychosis, but at the time of the protocol writing we had used the term FEP. New onset psychosis can refer to the onset of psychosis within the first 2 to 5 years, depending on the definition you want to use. For the purposes of our study, we use the definition of within the first 6 weeks of presentation to mental health care services. And I think what's important is, no matter which definition you use, the important thing is that this is a critical period in which we can provide a window of opportunity to improve outcomes if these patients can access care and hopefully remain in care. So there are many publications that suggest that new onset psychosis is much more common in patients who are living with HIV, and some people have suggested that this risk is up to 7 times higher in those who have had HIV in the past 12 months. Most studies, unfortunately, have not really looked at the clinical association and the impact of the HIV on the psychosis, but have just generally been prevalent studies on HIV in people living with these illnesses or comorbidities. So there have been some really good publications, both locally in South Africa, systematic reviews, chart reviews, lots of work also from Makerere in Uganda, looking at psychosis, first episode, cognition, etc., which have really helped us in planning our protocol as well. Also another useful article by Lahir et al. On HIV prevalence amongst first presentation of psychosis. So essentially all the literature has supported this bidirectional association between psychosis and HIV, but we felt there was still a gap in describing the first episode psychosis in people living with HIV. And studies have not systematically described how the HIV impacted on psychotic symptom onset in terms of positive, negative symptoms, cognitive profile, especially in the era where antiretroviral therapy is now freely available and accessible in South Africa. We also wanted to consider the role of trauma and substance use in these individuals. So we felt that understanding the contribution HIV made to these people may help us to have a better understanding of the pathophysiology and possible modifiable factors that influence psychosis onset. So the research question was essentially to compare the socio-demographic, clinical, trauma, substance use and cognitive profile of HIV-infected and non-infected patients with first episode of psychosis at baseline, so within the first 6 weeks of treatment initiation, and again at 3, 6, and 12 months. We essentially used a longitudinal descriptive quantitative study method where we are planning to compare 100 individuals living with HIV to 230 individuals who don't have HIV. Reason being, prevalence of HIV in this group is around 20 to 25% if you look at most of the studies. So, on the basis of probably a 1:3 type of comparison. Our clinical sites, there are 5 academic or teaching hospitals in the eThekwini region, which all have psychiatrists and inpatient and outpatient services. And we have been recruiting patients from these 5 sites, all very challenging clinical settings. So the clinicians are also fairly busy with the clinical work, but are also doing research. Our inclusion-exclusion criteria essentially are adults aged 18 to 45. We excluded the older patients because of the cognition issue, and with the first presentation of psychosis meeting DSM-5 criteria for psychotic disorder, and within the first 6 weeks of antipsychotic initiation. And HIV status is obviously checked by HIV ELISA. Some of the baseline assessments include clinical interview, physical examination, BMI, the MINI, the PANS, substance, depression, trauma scales, ESRS for neurological symptoms, a screening cognitive assessment at baseline, and then a full cognitive battery at 3 and 12 months. Hematological tests done in the unit are taken from the charts and included on our data. And this is the battery of cognitive testing that we are doing at 3 and 12 months. And this is kind of the plan we have in terms of the assessments that are done at baseline, 3, 6, and 12 months. So essentially, our journey began in 2018. I think we had full ethics approval by early 2019. We began the study in 2019. It initially began a bit slowly because it takes time for the team, I think, to also gather confidence, to know how to collect our patients. And just as we got full swing into data collection in 2020, I think we had the COVID pandemic, and we lost all our patients to follow-up, 90. Because our study was then suspended for a good 9 months. Because of the risks associated with COVID-19, there was no vaccination in South Africa at that stage. It was not feasible for us to have long in-person interviews. Option of telemedicine is not really a possibility with our patients. So we then started again after a break, and we've now managed to recruit in total 90 patients before and 90 patients after. So fortunately, we're back on the road. Longitudinal follow-up and retention is also extremely challenging in our setting because our patients come from far and wide. Often our patients are coming from as far as the Eastern Cape sometimes, northern Natal, rural areas, etc., and they go back home after they settle. And therefore follow-up for them is really incredibly difficult, although we do try and stay in touch with them telephonically. We have had a better response rates, but still a huge follow-up by 12 months. In our current sample, about 23% are HIV infected at the first presentation of psychosis. And most of the patients accessing care with first onset psychosis are male, but those with HIV, comorbid HIV, are female. So So it would appear that the females have a higher vulnerability to HIV than the males, which has been borne out in the literature previously as well. So some of our research outputs, we've been very fortunate in being able to use some of the preliminary data to present at congresses and managed to present both locally and also to the World Psychiatric Association, the Schizophrenia International Research Society, etc. So we've managed to put out some of the scientific evidence that we've collected thus far. We've done 2 publications, and I think the other part that we focused on is developing research capacity using this project. So some of our preliminary results, I'm not going to take you through them, but just illustrating some of the kinds of posters we've had over time. This is one of our manuscripts that was published. This was a systematic review and meta-analysis on the gene burden of HIV infection in first episode psychosis in Africa. The protocol paper was published in BNJ Open. Some of the posters. I think for me, one of the key aspects and what I wanted to kind of talk to you about today is that we are still a university with very limited resources, we don't have big funding, not much administrative support, but I think between the clinicians, we've managed to put together a study and to keep it going for the past few years. And I think what the study has allowed us to do is to attract at least 4 PhD students potentially. One is looking at the social cognition aspect, one is looking at the baseline clinical presentation in patients with first episode psychosis, and then also stratifying them by HIV status. Third, PhD student Dr. Jansana, who's here with us today, is looking at the trauma profile and looking at the first episode psychosis with comorbid PTSD and an intervention for that group. And then Dr. Taylor, our neuroscientist, is looking at the CSF biomarkers. We just have fingers crossed for ethics approval now. So hopefully the study, which began very simple and easy, what we're trying to do is get new grants and add on sub-studies. So hopefully it then allows the researchers to already build on something that's already existing. We were hoping to also try and do a neuroimaging study, which didn't quite work, but maybe sometime in the future. We've also now started our first master's projects with this lot of data. We had collected blood specimens from the patients at baseline, and we are using that to look at the serum peripheral inflammatory biomarkers. And one of our residents will be doing that study. We are also looking to do a qualitative study on the lived experiences of people with psychosis during the COVID pandemic, which Ms. Julie is going to be leading, hopefully, once she gets this conference out of the way. And we're also looking at some non-degrees work. So Prof. Tulisa has led a new grant initiative which has allowed us to begin the sub-study rematch. Rematch looks at the impact of COVID on people living with psychosis. So it allows us again to continue this cohort for another 2-3 years. The funding is for 3 years, and it will allow us to add another 90 participants to the cohort. The psychology group is also working on a systematic review looking at the hinting task. The hinting task is a psychological tool that one uses to assess social cognition, and one of the issues we have in South Africa and Africa, I think, is validating tools to actually measure what we want to measure, and we don't really have a proper tool to measure social cognition. So we're looking at what is the utility of the hinting task in low and middle income countries in terms of assessing social cognition in people with psychosis. And also very pleased to announce we're hoping to now collaborate with Dr. Maru Mihoko, who will be hopefully doing some work on our project and helping us to write up some of our papers now that we have a fair bit of data. So what have we learned? Well, we've learned, I've got a lot of gray hairs, but I think the first thing obviously is the science of any research project. There must be, no project is ethical without having some scientific validity. So we are learning about first episode psychosis and the association of HIV and psychosis. But I think more importantly, we're also learning how to manage a research team, understanding what goes into doing a research project longitudinally and how we can improve our capacity to do this work. It's allowed us to learn about funding, unfortunately, applying for grants, writing grants. We don't have grant writers, so it's a lot of late nights. Administration of a project and filling in forms and trying to get through your university in terms of getting something done. And I think for us another important lesson is how to develop research capacity within the department, how to provide mentorship to young emerging clinicians who are maybe wary of doing research because our backgrounds are very clinical, and the thought of now having to add on a PhD to your workload is often quite challenging. So providing them with that necessary support is quite important as well. And also we don't want to lose everyone to private sector, so if we could try and keep them in academia and keep them stimulated, that helps. So I think we have learned a fair bit. We sometimes have made mistakes, but hopefully at the end of the day, our new sub-studies will be much more richer and more scientifically advanced. So looking towards the future, I think we would like to build on this study. We would like to maybe look at international collaboration, which always brings in more ideas, new insights, new ways of doing things. So we look forward to that. And I think the next step for us, this was a very descriptive study which just describes the population as is to move on towards more interventional work so that we give back to the population that we have had the privilege of following. And so hopefully over the next year or two, we start planning work where we can provide more psychosocial interventions to augment the medication that these young people receive from us. So in terms of acknowledgements, it takes a village. And I've been very fortunate to have Prof. Kaliza by my side, so whenever I have a major problem, I'm WhatsApping him. But we've also had a good research team and support staff, including our research assistant and administrative staff at the university who have helped us with all the admin. Our funders, we are thankful for having received these grants and being able to get this project off the ground. The University and Department of Health for allowing us to do this project. And also, we have fed off our colleagues in Stellenbosch. We visited with Professor Robin Emsley and his team, who have always been supportive, shared tools with us, translations, and given us advice where we're not sure on how to proceed with a certain part of this project. So I think it also helps to have some collaboration, work with others. And maybe that's some of the things that we can look at. Universities have already done research, helping those that don't have any research at the moment in terms of starting a little project and partnering with someone. Okay, so I think that's my bit for today. Thank you.
Thank you so much, Saeeda. I think in the interest of time, we're going to move forward, and then hopefully we have a couple minutes at the end for questions.